Good afternoon, everyone. I'm Jia from Taichung Metro Harbor Hospital, and I'm excited to share a challenging case of Sinonasal undifferentiated carcinoma, or SNUC, in a 69-year-old man with a complex medical background. And let's get started. Our patient was a 69-year-old gentleman with a heavy medical load. He had end-stage renal disease requiring weekly hemodialysis, hypertension, type 2 DM, and coronary artery disease with myocardial breach. Despite this condition, he was managing pretty well until he developed new symptoms: intermittent nasal obstruction, postnasal drip with yellowish sputum, and progressive pain and swelling in the right maxillary area. He reported the pain was worsened with cold exposure, but was partially relieved by medication. On physical examination, we found mucus retention in the right maxillary sinus and edematous nasal turbinates. Labs show anemia and elevated neutrophil to lymphocyte ratio and poor renal function, expected given his ESRD, and the tumor markers were all normal. A sinus X-ray showed asymmetry, so we ordered a CT scan. The result was worrisome: sinusitis with a mass, possibly a mucocele or tumor. It starts in the right maxillary sinus and extending into the right orbital cavity and infratemporal fossa. To get a definite answer, we proceed with a partial maxillectomy. Pathology confirmed Sinonasal undifferentiated carcinoma with focal invasion. Immunohistochemistry clarified the picture. It is strong positive for CK cytokeratin, but negative for CK7, CK5, MYOD1, and myogene, ruling out adenocarcinoma, squamous cell carcinoma, and rhabdomyosarcoma. And the tumor also showed intact nuclear stent of SMARCA B1 and SMARCA A4 expression at 100%, supporting the diagnosis of SNUC. A PET scan mapped the extent, involvement of the right maxillary sinus, orbital cavity, infratemporal fossa, and buccal region, and maxillary bone, with a tumor size of 4 cm and an SUV max peaking at 19. And no FTG-avid lymph node or distant metastases were seen, staging this as a CT4A N0M0 stage 4A per the AJCC 8th edition. The patient opted for concurrent chemoradiotherapy, and we used paclitaxel at 60 to 80 milligrams and carboplatin at 50 gray. Radiotherapy was given with 74 gray in 37 fractions to the primary tumor, and 50 grays to the right neck, and 45 gray to the left neck, aiming for local control while navigating his fragile health. Unfortunately, the treatment wasn't smooth. He experienced significant side effects, including fatigue, oral mucositis, and neutropenia, which made him prone to infection. He developed infection with ESBL producing Klebsiella and carbapenem-resistant Pseudomonas aeruginosa. And when oozing forced us to pause CCRT for about 2 weeks to manage this infection and complications. After resuming and completing treatment, we saw some improvement. His eyesight partially recovered, which was encouraging. However, new issue emerged. He developed a herpes infection over the right upper face, but his renal function made acyclovir poorly tolerated, limiting the options. So despite completing the CCRT, his overall condition deteriorated. His advanced renal failure and the aggressive nature of the stage 4A SNUC made us painted a grim picture. So after discussion with the family and our multidisciplinary team, we made the difficult decision to discontinue hemodialysis, and his decline was rapid. He passed away 5 days later. Last, SNUC's rarity and aggressiveness made it challenging, and his comorbidity, particularly ESRD, amplified the treatment toxicity, and the lack of metastasis gave us hope first, but didn't pan out. So I'd like to to discuss on these points. First, for an inoperable SNUC like this, would you go straight to definitive CCRT or try induction chemo first? Second, do you treat elective cervical lymph node for maxillary or ethmoid SNUC? Third, what radiation dose would you choose? Ours was 74 to the tumor, too much or too little. 4, would you consider proton therapy, carbon ion therapy, or BNCT here? 5, if using induction chemo before CCRT, do you include the entire pre-chemo volume in the high-dose CTV? And the last is if CCRT gets a prolonged break, like our 2 weeks, when do you boost the radiation dose? And this is my sharing.
All right. Well, thank you so much for. Is this working? Can you hear me? Well, thank you so much for presenting that case. Very, very interesting case. Very unfortunate case. I thought we would introduce ourselves first. My name is David Yu. I'm at University School of Medicine, professor of radiation oncology, and I treat head and neck and breast cancer patients. I think there. Yeah, let's go to questions. I mean, I think there's a number of things that were unfortunate. Number one, it was a very relatively advanced disease. This is very rare cancer. As we all know, the outcome is quite poor. Survival rates probably at best 50 percentile. There's also a treatment break. I can't recall how long, like 2 weeks or something?
2 weeks.
So that, as we know, also impairs outcome in head and neck cancer patients. About 1% impairment, 1 to 2% impairment in local control for every day extended beyond the intended treatment dates. So, in terms of the questions, what would your treatment approach be for this inoperable SNUC patient? I think there's pretty extensive disease, and often if there's extensive disease and you have concerns about coverage or overdosing of critical structures, such as your optics, I think doing an induction approach is very reasonable. There is a clinical study, Nabil Saba's ECOG study that did induction chemo followed by surgery and post-op chemo-RT. Or there's also a recent JCO paper where they did induction chemo, and they found that if the patients responded well, they went on to actually chemo-RT without resection. Whereas if there was not good response, they did have resection, but those patients ended up doing like a lot worse. And so I think it's reasonable to do induction. Of course, the challenge here is that the patient has end-stage renal disease. But I think doing something like carbotaxol instead of cisplatin would be a reasonable approach. And we often time this with dialysis also, doing the chemo and then kind of doing the dialysis, like the day after. So you're minimizing toxicity. So you can still offer the induction chemotherapy in that context. I think the approach that was used is reasonable. Unfortunately, it's just a very aggressive case. Do you want me to just go through all the questions, or you want to enter? Yeah, if you guys have any questions along the way, just please. I don't know why this is. Maybe you have to hold it very close. Yeah.
Would you manage the patient differently, or you have any different approaches? Would anyone do induction immunotherapy with chemotherapy? No?
Immunotherapy is another option, right? So there's a study where they're going to do perioperative pembrolizumab, which, although this is like an unusual case, is not an unreasonable option given this patient's comorbidities.
Right. So I can chime in here. So I'm Jillian, I'm at Princess Margaret, and previously I practiced at Sloan Kettering. So I know different institutions have different approaches. At Sloan Kettering, probably the patient would receive induction chemo or chemoimmunotherapy on protocol. It is very rare to go through definitive chemo radiation if the disease was so extensive. But it's not unreasonable, though. It's like it's also one of the standard of care options. But then at Princess Margaret, sometimes we do preoperative radiation plus minus chemo. So it's almost like a sarcoma approach that you do a pre-op 50 gray without elective, just the primary, followed by surgery. So that's also another approach that I've seen. I cannot comment on the randomized evidence because I think that's a single institutional preference. But that's something that we probably would do at Princess Margaret would be preoperative radiation plus minus chemo to 50 gray instead of, and then followed by surgery. Yeah.
For the surgery?
Yeah. So if we are to do preoperative radiation with or without chemo, usually we work with the surgeons to define the area. So we might or might not want to focus more on the area that they are concerned about positive margin, because you don't really have to do radiation to the very superficial areas that are going to be resected, right? So they are concerned more about the deep areas for margin. So sometimes you work with the surgeon and you define the area of the preoperative volume, and with or without chemo, and then followed by surgery. So that's another approach. That's not there's no level 1 evidence, but there is some good outcomes about margin negative resection after the preoperative radiation. So that's something that's a single institution preference. But I would say probably more standard would be induction chemo or chemoimmunotherapy.
Next question, do you treat elective cervical lymph nodes for SNUC of the maxillary ethmoid sinus? I would probably treat level 1 to 3, certainly depending on whether it's well lateralized or more central, treat unilateral or bilateral neck. I mean, this is like a T4A also, so relatively more advanced. So you might be a little more generous in terms of coverage with nodes.
Yeah, I would do the same. I will also do the RP, electively, given the tumor location. But that's pretty standard. Yeah. And radiation dose for definitive is 70 gray. Postoperative would be 60 gray, 60 to 66 gray. Right?
Yeah, I agree
standard.
with that.
Radiation modalities. I think if there was proton or carbon ion option available, that would definitely be considered. But again, I think it's equally toxic in this setting because of the large volume.
Yeah, I mean, can you get potentially better conformality? Maybe with proton and carbon ion. I mean, the advantage of carbon end is certainly like you have higher RBE, higher LAT, so potentially more efficacious. Although not many places offer it, right? So that's how many patients have treated SNUC with carbon ion therapy? It's probably very few, right? So there's some unknown with that also. I mean, even BNCT. I don't know too many places that necessarily. Maybe you guys do it at Princess Margaret Hospital, but we certainly don't have a lot of expertise in it. But certainly, I mean, it doesn't hurt to get a second opinion somewhere. But I just think that you're going to be limited by how many institutions are going to offer that option.
I raised this question because we see the tumor grows during the treatment. Mm-hmm. We see it invade the bone in the daily imaging. So I think it is a really radio-resistant tumor. So that's the reason why I asked this question.
So are you doing like kind of daily cone beam CT and you're kind of seeing the progression growing through the radiation treatment? Okay.
And chemo. So
well, in which case, I think higher RB like carbon ion or might be more effective, or it just might be so radio-resistant you're not gonna. Doesn't matter what you do. All right, what are the questions?
So the induction chemo, Assuming that if the patient did have a really great response, then definitely we would treat, we would treat the residual tumor to the high dose, and then the pre-induction disease that's regressed to an intermediate lower dose, like similar to what we would do for the nasopharynx after induction.
Yeah, we always take into account the pre-chemo volume also, but take into account the new anatomy right after the induction chemo. I mean, obviously you're not going to treat something that's extending outside the body or an air cavity or anything, but I think those areas all are potentially at risk. I mean, if you imagine like in a very extreme situation where you have like a complete response, I mean, you're not going to not treat it. So we would still treat that, but certainly like target the residual disease, certainly a higher dose, especially if you can come off of like the optics and other critical structures.
All right, I think the last question, the prolonged break, like for this particular patient, we probably wouldn't do anything because this patient, you knew he wasn't going to do well, even if you increase the dose. Typically we add 1 fraction per week of break. So it's just a general rule, but for this particular patient, given that he was already doing very poorly, probably it wouldn't be helpful to add 2 more fractions. But in general, we would do 1 fraction per week of break.
Right. Yeah, we'll get our physicists to make that calculation, and how do you compensate depending on how many days are missing. What are we compensating for, right? So it could be an extra fraction, or maybe like we'll do kind of like the HANCA, like a 6 fraction BID every 5th day to kind of make up for lost time. But yeah, I agree. I think this patient probably, I mean, even if you gave more dose, I mean, they're probably still not going to do well, unfortunately. Yeah. Any other questions regarding this case or anything related to it?
Or comments? No? All right.
Anyone would do anything differently? Okay.
Your case.
I don't know if it's my case or yours.
The next one's yours.
Okay. All right. Okay, so, all right. Okay, I will advance the slide. Okay, so we have, okay. Maybe I'll move this. All right. Oh, no. Okay, no. That's fine. Oh, we're sliding. Oh, okay, you're strong. All right, so this is also kind of an unfortunate case that was presented in our morbidity and mortality conference by one of our residents. This is a 42-year-old male, initially presented with odontoctalgia in the right lower part, back of his mouth, and admitted for extraction. There's a cystic lesion found actually on the other side. And history otherwise is not that remarkable. No significant past medical history, family history, nothing. He is a daily smoker and occasional alcohol user. No prior radiation therapy, no cardiac device, no systemic vascular disease. So biopsy was done, pathology returned the following. Basically on the right lower jaw lesion, there was invasive squamous cell carcinoma, moderately to poorly differentiated non-keratinizing. And then subsequently CT soft tissue neck with contrast showed extension of the tumor from gingiva to lingual surface and associated with the cortical erosion. Also multiply enlarged level 1 to 3 nodes. So you can kind of see these are kind of like level 2. You have just kind of a semi-level 1B node that looked enlarged. And additional kind of level 2, level 3 nodes. It's almost like a level 1A kind of node here that looks enlarged. And also there was appeared to be adenopathy, kind of in the lung area. And so we actually have this kind of integrated here, but this is a PET scan. So there are some sites that kind of lit up in the neck. Yeah, even the lung one kind of lit up there also, but how do I advance this? Okay, so, but ultimately the patient had bronchoscopy of the lung lesion and that was benign. And I believe like it was tried twice and found no evidence of disease. So ultimately the patient was staged as a T4A N2C M0. So patient had surgery, composite oral resection, including right segmental mandibulectomy, right buccal resection, right floor mouth resection, had a neck dissection on both sides, right and left, a tracheostomy with a Bjork flap. And the pathology showed invasive, moderately differentiated keratinizing squamous cell carcinoma invading the bone, 2.54 centimeters in greatest dimension, 1.7 centimeter depth invasion. There's positive LVSI, but no perineal invasion. So this is staged as a PT4A. Margins were all negative. The closest margin was 0.3 centimeter deep margin. And similarly, 0 out of 68 lymph nodes were pathologically positive, despite being enlarged and also kind of PET-avid. So I mean, they potentially could have been reactive nodes. So this is a CT simulation. You can see kind of some of the resection. There's some areas that were kind of concerning, looked kind of necrotic in certain areas. Also resection bed was, there's an enlarged node there that was kind of highlighted. Okay, so let's kind of, how do you do this? How do you advance? All right, so, okay, so this is the CT planning, and this is a post-op case because there was some discussion and multidisciplinary tumor board about kind of the margins and, somewhat close. We elected to treat post-operative 63 gray with the prophylactic sites treated 54. And kind of go over that. So 63 gray went to pre-op tumor and post-op resection bed plus margin. The 54 C54 went to elective nodal regions in 1 to 4. And there was some question about, on the CT scan, there were some sites that were looked like there was still some adenopathy. That some question about whether we should cover or not, even though the patient had, essentially 0 out of was it 60 or 70 lymph nodes that were positive. So the question is, would you have covered some of these nodes anyways? Usually, if it's like necrotic or substantially enlarged, we may consider it. Or if it's like right, kind of near the field anyways, and it's not much more morbidity, we'd probably just cover it anyways. Oops. So what happened next? Patient returned, had a follow-up PET scan. which I'll kind of just scroll through here. Basically, what was found, interval post-surgical changes of TORS and neck dissection with persistent focal FDG uptake along the surgical bed concerning for residual recurrent disease. There was interval increase in number and metabolic activity of cervical, mediastinal, and hyaline lymph nodes concerning for nodal metastasis. And an FDG avid pulmonary nodes new when compared to prior scan concerning for underlying metastatic disease. So this patient had biopsy and unfortunately was found to have residual/recurrent disease. Even bronchoscopy now was positive. So essentially the patient had met it out and unfortunately just didn't do well here. The patient was considered for single-agent pembrolizumab, but did not start. And then later on found to have dyspnea, found to have progressive left hilar mass leading to occlusion of left main bronchus and collapse of the left upper lobe, and some concern for post-obstructive pneumonia. See how to advance. Bronchoscopy, showed invasive squamous cell carcinoma with extensive necrosis. And patient got some palliative lung RT and then also pembrolizumab. I mean, I can just kind of advance beyond this too. So kind of questions for the group and learning opportunities. How aggressively would you cover your CTV? Would given 0 out of 70 notes, would you still cover all these nodal areas? How aggressively would you cover? Would you cover those sites that had some concern that looked somewhat enlarged on a CT simulation scan? We generally would include it if it's, in proximity, if it looks necrotic or looks kind of malignant, we'd probably cover those sites. Because it's possible that patients have very aggressive disease that will have progressed even from surgery to by the time you're simulating the patient. Ideally you want to treat within, 8 weeks or less, but sometimes they show up a little later. So there could be some time for progression.
Anyone? Okay. So this is very interesting. You do see those patients pre-op, right?
Correct. Yeah.
Yeah. Yeah. So usually, if I see those patients pre-op, I would just time their surgery and then order a post-operative PET at 1 month. It varies because I am the only one in my institution that does that. If you are worried, I guess you can pick up the interim metastatic disease before your radiation. But many times the surgeons and also radiologists, they don't like the postoperative PET because it can be very noisy. I sometimes selectively do it for the T4 or for those patients that we were very suspicious about metastatic disease at the time of diagnosis. So I would time their surgery, and when I schedule their follow-up, I would order a PET at 1 month after surgery, and then I see them back for radiation planning. But again, it may not show anything. I think for those patients, sometimes I think anecdotally, the borderline metastatic patients after surgery, because of various factors, they do met out.
Yeah.
That's one.
Yeah.
That's one thing. But I think the CTV coverage would be very similar to what you have covered.
Right. The question, which with all nodes negative from neck dissection with presence of new level node at level 4, would you be suspicious reactive adenopathy or concern for disease? Right, so kind of addressing kind of that same question. Should lung have been managed differently? We did get biopsy, which I think it's kind of the gold standard to see whether they're indeed have, either metastatic or a second primary cancer. But usually for lung patients, we'll often give benefit of doubt and treat aggressively as if they were not metastatic. Any other changes in care?
I have a question about the atypical cells in the lung. Do they know why that was atypical? Yeah, was that like sampling that because if you're doing cytology, you may not be able to see the invasion, right?
Correct.
Would it be maybe highly suspicious to begin with?
Yeah. Yeah, I agree. With an FNA biopsy, you might not be able to get it as well. So it might increase your index of suspicion. Metastatic disease. That's all I have. I don't know if anyone else have any comments or questions, or maybe how you might approach this case a little differently. It's an unfortunate case. This patient just didn't do well. But it's possible he probably already had metastatic disease to begin with. Yes.
Did this case have concurrent adjuvant chemo with the radiation therapy?
Yeah, so this case didn't necessarily have indications for post-op chemo RT, which usually it's like positive margins or extracapsular extension. Our medical oncologists often will be aggressive if there are multiple kind of intermediate risk factors, but it was not considered in this situation.
Okay, thank you.
Sorry, I wonder, does this patient have an initially left hilar PET avid node?
Yeah, it was initially PET avid, but it was biopsied and it was negative.
For once, only once?
I think it was twice. I think it was negative, yeah.
Oh, really?
Yeah.
Because I think from the image, we can assume that the SUV max is very high. I don't know about the nuclear report. I don't know. So, yeah. Maybe in our institute, we will do maybe third or confirm with the nuclear medicine doctors.
Yeah.
Okay.
Sometimes you do see, it depends. Sometimes you do see granulomatous changes that they are FDG avid, but they are, when you biopsy, it's granuloma. It's not cancer.
Yeah. Okay. I have another.
All right. Okay. Okay. All right. Okay. So for my interactive cases, I have a couple things to go over. It's more about volume contouring, because I was thinking this might be a contouring session. But so I'll go over, and then there are some interesting differences I think some of you might appreciate. Straightforward, 89-year-old man, 20-pack-year history of smoking, hoarseness. You see the true vocal cord lesion, you biopsy and show invasive squamous cell carcinoma. Very straightforward, right? And it invades one cord, maybe approaching the anterior commissure, but does not cross to the other cord. There's no supra or infraglottic extension. The CT of the larynx, first of all, when we do the larynx preparation, if they only get a CT of the head and neck or the neck, but if it's a larynx case, I would order a CT of the larynx for radiation planning because the larynx is slanted. It's not parallel to it's not directly parallel to the body, so the larynx has an angle. So when they do a dedicated CT of the larynx, thin slice, that's 1 millimeter, they also angle it so you can see the plan parallel to your cord. It doesn't cut through a different angle of the cord, so you can see the entire length of the cord. And when you outline your, the case, that's better visualized specific for larynx. This is just CT of the neck. So this is not dedicated to CT of larynx, but there's no adenopathy, there's nothing. So it's very straightforward, T1A and 0, early stage larynx. Many treatment approaches. Does anyone still do this field-based treatment? Can you raise your hand if you're doing your field-based treatment? Okay, don't be hesitant because that's a very good answer. Okay, so standard, when I was in training, what I was taught, to define the field, and you can see, from the thyroid to hyoid, and it's a 5x5 field, right? So for the T1, typically the Japanese does 63 gray in 28 fractions, or sometimes you do 66. That's rare. For the T2, you just add one more fraction. So very standard, right? And then there is the different method. People started doing IMRT in the early mid-2000s. There's been different publications looking at carotid artery sparing. I think for an 89-year-old, probably not very relevant. Okay, so but then people started doing IMRT for this, and then you do get better conformality. But I think the toxicity is the same because you are still treating the entire larynx. So your benefit is really carotid sparing. I don't think the toxicities are different compared to the field-based. And this is what I was treating early on in my career at Sloan Kettering. I was doing IMRT, I contour. So basically, instead of defining the field, you just contour the larynx, the whole larynx. Plus margin gets 63 gray, and then then you contour the carotid, and then they somehow spare it with VMAT or MRT. So that's method 2. Then method 3, when I got to, because toward the second half of my career at Sloan Kettering, we started hearing about single vocal cord radiation. Because if you think about the surgeons, they do laser, they don't laser the entire larynx. They do just whatever the cord that's involved, they do the cord. So there has been no large-scale publication, unfortunately. I know Princess Margaret has been doing it for decades, but I don't think they have really published the data. So when we started doing it at Sloan Kettering, we were not sure how they did it. So basically, we just do hemilarynx, not this approach. So we just contoured half of the larynx, and then we angle our beams differently for VMAT. But if you do that plus margin, you still get pretty much the whole larynx covered, right, for the PTV. Then when I arrived at Princess Margaret, I found out that actually they're doing it very differently than what we did, because we were just communicating, oh, you do hemilarynx, you do one core. So we're just doing this our way, this way. So I found out that, first of all, their dose fractionation is very different. It's 51 gray in 20 fractions. So I don't know where this came from, but they've been doing this fractionation for a long time. The outcomes are good for the T1 larynx. And I think it's particularly relevant for an 89-year-old man that you don't want, you're less concerned about, you're more concerned about toxicity and you want to shorten the duration. So for the T1, the option that I've been doing right now is 51 gray in 20 fractions. And there is a dose painting. So if you look at the contour on this case, the red is 51 gray. So that's the GTV. You contour that involved cord. It's still very generous because you don't know. I just contour the entire length of that cord. and then your GTV plus margin, the first margin would be the 51 gray. That's a CTV 51 with a proper expansion, which I'll show you. And then, but then you want, then the CTV2 is another expansion of CTV1, but that's covered to only 45 gray. So there is a dose gradient compared to what I did before. It's just everything is 63 gray, right? So hemilarynx 63 gray or just whole larynx 63 gray. This approach is very tolerable. I've treated so many patients now. So you're really just focusing on the 51 gray in the GTV plus margin. The rest subclinical dose is 45 gray. Moving to T2, if there's any suspicion of impaired mobility or any suspicion of T2 disease, the treatment becomes more toxic. It's very similar to other T2 treatments, 66 in 33. And then at Princess Margaret, we do Dahanka. So I think it's actually very toxic. But for T1, it's very tolerable. So if you look at this approach, this is very small. I can't read. So, okay, so the CTV, you contour the GTV, right? And the CTV primary 51 is just 3 to 5 millimeter expansion to your high dose. And then CTV2, that's the 45 gray, another 5 millimeter or so expansion. So that's your contour. But then the planners put on the PTV. So the PTV, because of the setup uncertainties, especially for larynx, the PTV margin is actually pretty generous for larynx. Because I think it's 1 centimeter sup-inf and 0.5 around, because you have the sup-inf variation, that's more. So you end up having this plan. It still looks sort of like hemilarynx, but there are 2 doses instead of 1 large dose. You have the red, that's 51 gray. Then you have the orange, that's the PTV orange, that's 45 gray. So you're effectively sparing the other cord of the 51 gray. So I think the other cord mostly, except for the anterior commissure, you received 51 gray, but the rest receives like 45 gray or less. For an elderly man, this is very tolerable. When I was using my previous treatment approach, they still get pretty sick toward the end. It's okay, but for this, many patients don't even require strong pain medicine. They take Tylenol and they're done. They go through the treatment. So this is something that I learned going to Princess Margaret that I found very appealing for the T1 larynx.
Do you have any data on failure rates?
Yes. So the thing is that they don't publish, but there's no failure. There's no more failure rate. They're actually putting together a manuscript because they have a very good database. They are not. There's no increased failure rate compared to the conventional. So then the Sloan Kettering started doing this hemilarynx differently. So they are actually publishing their rate too, and it's very similar. So that's something that might be considered once the publication is out, because they really need to publish this. But we keep everything because all the patients, they are followed. They're not going to move around because they are all in the same province, more like in Taiwan, right? Because you have the central healthcare, so you really track them, and they're really actually doing very well. Okay. Any question? All right. So the next one is oral. Also, yeah. Okay, 5 minutes. Okay, very straightforward. Very good. Very straightforward. Oropharynx HPV positive. Okay, T2 left tonsil, N1 single node, P16 positive. Okay, then normally you either go for surgery, TORS, followed by radiation alone. So this patient elected to go to definitive chemoradiation. So that's one patient. I'll go through both. So then there's one more advanced 50-year-old, smoker, weight loss, larger base of tongue tumor. You can see, and then if you look at the CT, I don't think I have do I have the MRI? So if you look at the CT, I think there is a extrinsic muscles of the tongue involvement, and there was an MRI that showed more. So this is classic, technically a T4 because of extrinsic muscle of the tongue involvement. And you can see the lymph nodes in the level 1A area and 3, okay? So it's T4 and 1, and biopsy still shows P16 positive squamous cell carcinoma. So both patients elected to proceed with definitive chemoradiation. The regimen of the elective dose, okay, so we are not talking about de-escalation, especially for T4, they need to be treated with 70 gray concurrent chemo. But do you still need to do 56 or 63 gray to the elective nodes? If you look at the published trials, it's all over the place, right? So there is no standard elective nodal dose for these patients. So very fast, since 2017, we've been lowering our elective dose to 30 gray at Sloan Kettering, and I'll go through this very quick. I'll show you the contours. Okay, so for a patient, you're very worried about, say, this is a primary tumor, that's T4, that's clearly T4. So you have PET and MRI simulation. So you contour this GTV red based on your MRI and PET and CT PET fusion. So we are not skimping on the primary disease. It is still GTV 70 gray plus margin to the PTV, right? But then for some people that are very worried about, the margin around this GTV, sometimes there is a 50 gray around it, or a little lower dose. But if you see the neck, the uninvolved lymph node in the elective region, we lower the dose to 30 gray. So it's 30 gray in 15 fractions, then calm down 40 gray to the gross disease and lymph nodes, okay? Same, if you have a T4 disease, big lymph nodes are not being skimped on the dose. Gross disease still 70 gray, but you see even for the primary in this patient, the primary margin around it, the elective, everything is 30 gray. The blue, some people are very worried about very small nodes, so they give it to intermediate dose like 50 gray. It's judgment call, but definitely elective nodes that's negative, or the margin around the primary, that's 30 gray. Same, this is just another example, 30 gray, then calm down to the node and gross disease. That's a CTV, and then you do the margin to the PTV, 1 minute. So that's a substantial savings on your toxicity because of the elective dose. So we followed 276 patients. None of them recurred in the elective node. They all recur in the 70 gray, because when they're recurring, the 70 gray is just very resistant. So that's the approach that we have been doing since 2017. Thank you.
Great talk, Dr. Tsai. Can I ask 2 quick questions? Yeah. So first is, are you doing the 30 gray for elective nodes for only HPV positive patients or for all kind of SCCs?
Only for HPV positive patients on chemotherapy. Okay. So you're doing definitively, because chemotherapy can eliminate some subclinical disease. So without chemo, you might have to raise the dose of elective, yeah.
Mm-hmm. And second question is, what are your thoughts on omission of ENI in carefully selected patient populations, like the inner air trial?
So we have a lot of phase 2 trials that you can actually omit, especially the next station or the contralateral ENI. So the contralaterally, you don't have to treat 2, 3, 4. You can treat just level 2, because we have phase 2 data showing that contralateral, if you're not omitting, because if you're at base of tongue, that's cross midline, but the contralateral node is still negative, probably covering just the level 2 will be sufficient, but we need longer term follow-up.
Is that something that you're doing at Princess Margaret already?
We did a phase 2 trial.
Okay.
We haven't decided if we are to do more trial or just adapt. Yeah.
Okay, great, thanks.
好。
One simple question. For early regional treatment, how do you overcome the internal organ motion? Because the margin is very tight. What's your opinion?
So you have daily cone beam CT.
Yeah, but during the treatment, maybe the swallowing, so be.
Oh no, they cannot swallow. So they cannot swallow during treatment. Yeah, there's definitely no swallowing. Yeah.